we are here for anyone who has questions. Okay, so I'm going to start the slideshow.
Incidence of 53 per 10,000 births. It is the most common congenital.
Apologies, let me just go back. Okay.
Good afternoon, everybody. We are part of the rehab team at Nelson Mandela Children's Hospital, and today we will be presenting on ventricular septal defects. Ventricular septal defects have an incidence of 53 per 10,000 births. It is the most common congenital heart defect and occurs in 50% of children with congenital heart disease. In 20% of these cases, the VSD is isolated. The VSD occurs when there is disruption in the interventricular septum. When we take a closer look at the interventricular septum, we can see that it separates the right and the left ventricle. IVS can be separated into two morphological parts, the muscular and the membranous septum. The membranous septum is located below the right and non-coronary cusps of the aortic valve. IVS has multiple embryological origins. It forms from three septa, namely the muscular, the outlet, and the inlet septa. If during embryological and early fetal life there is abnormal completion of the IVS, a VSD will form. Development of the IVS starts at 5 weeks of gestation. Firstly, a muscular portion of the primitive ventricle grows upwards towards the endocardial cushions. It doesn't quite reach the cushions and forms the primary interventricular foramen. A membranous portion originating from the aortopulmonary septum and the endocardial cushions grows downwards and closes the foramen. The IVS will be completed by 8 weeks of gestation. There are various types of VSDs, and each should be assessed for its location, its size, and if there are multiple deflects. Perimembranous, depicted in yellow, is the most common and occurs in 75 to 80% of cases. These are often associated with misalignment of the aortopulmonary septum, as in tetralogy of Fallot, or in interrupted aortic arch. A third of these will close spontaneously. With closure, there may be a risk of the development of aortic regurgitation. The muscular VSD depicted in blue contributes to 5 to 20% of VSDs. These occur in the trabecular area of the IVS and are entirely surrounded by muscle. 68 to 75% of these will close spontaneously. Inlet VSDs, depicted in green, occur with endocardial cushion defects and are often seen in trisomy 18 and 21. They are often associated with ASDs and atrioventricular valve defects. Subarterial or outlet VSDs are located below the semilunar valve, and 5 to 7% of these are isolated VSDs. They are often associated with aortic valve relapse and regurgitation. A French study looked at 1,178 hearts with congenital heart disease and found that in 62% of these, the VSD was present. 72 of the hearts had an isolated VSD. 96% of complex anomalies of the atrioventricular connections had VSDs. When looking at main subgroups of VSDs, the majority are outlet VSDs. Pathophysiology of VSDs. In prenatal life, systemic vascular resistance is equal to pulmonary vascular resistance, and therefore there is limited flow through the VSD regardless of its size. After birth, PVR decreases and SVR increases, so there is a left to right shunting of blood. Pressure gradient as well as the size of the VSD will determine how much blood crosses the VSD. In a small defect, there is limited shunting. However, shunting increases with increased size of the defect. Blood flows from the left ventricle to the right ventricle. There's an increase in pulmonary blood flow, which may cause pulmonary hypertension. There's increased preload on the left atrium and ventricle. Small VSD is usually asymptomatic. With chronic shunting or a large VSD, structural and functional changes will occur in the pulmonary vasculature. This, in turn, increases PVR and results in worsening pulmonary hypertension. When the PVR exceeds the SVR, the shunt will be reversed and Eisenmenger's complex occurs. Cyanosis will be apparent.
Looking at the VSD in terms of health history and health assessment. A British Journal of Nursing released an article by Scott and McInnes that looks at the process of a cardiac patient assessment, with emphasis placed on the patient being put first. 6 elements are included within the article, where they talk about past medical history, family history, social history, medication, assessment of risk factors, and clinical assessment. Looking at past medical history in more detail, when obtaining collateral of patient history information, it is important to note any associated congenital heart defects, such as your atrial septal defects, your patent ductus arteriosus, your aortic coarctation, your right aortic arch and pulmonary stenosis, your substenotic stenosis, and specifically looking at your complex congenital heart disease, such as your tetralogy of Fallot, univentricular atrioventricular connection, and your transposition of your greater arteries. It is also important to note the presence of any other comorbidities. Further collateral information and health history should include interviews with direct family members, if possible, to identify genetic factors that may be identified through family history, such as your chromosomal factors like your trisomies, your 22q11 deletion, and your 45x deletion. In conjunction with your chromosomal factors, a single gene mutation or polygenic inheritance can also be present. Your single gene mutations are at high risk of reoccurrence in the first 3 relatives, whereas with your polygenic inheritance, no genetic testing happens, but the recurrent risk can be used for genetic counseling for future pregnancies. Another aspect to take note of is her social history, which in our older population would include an assessment of risk behaviors, such as their habits like smoking and abuse of substances or use of substances, diet and level of physical activity and exercise. Notes of other social history, which can be further obtained in more detail from a social worker or from a case manager, may guide the practitioner in their approach to intervention and management. Within different contexts and cultures, it is important to look at medications that the patient is currently taking and that they've taken in the past. Within the South African context, practitioners are often presented with cases that have first either been managed or seen by traditional healers, and so it's important to note that any use of herbal substances or medications, as well as any traditional procedures or practices that may influence the patient's presentation and further management. Assessment of risk factors aids the practitioner further. It is important to take note of non-inherited risk factors, such as your maternal infections, like your rubella, influenza, and febrile illnesses, as well as your maternal metabolic illnesses, such as pregestational diabetes and phenylketonuria. Also linked to VSD is exposure to toxins such as alcohol, marijuana, cocaine, metabolic medications, such as your ibuprofen and your metronidazole. When performing clinical assessments, the common practices of obtaining vital signs, inspection, palpation, percussion, and oscillation should be followed. These processes should reveal the following common symptoms: respiratory distress, such as dyspnea, tachypnea, and hypoxia, heart failure symptoms like edema, fatigue, wheezing, sweating, and irregular heartbeats, pansystolic or holosystolic murmurs. And in terms of your pansystolic murmurs, it's important to note that smaller VSDs are usually a louder murmur can be heard and they're associated with the flow, whereas with your larger VSDs usually have a diastolic rumble at the apex. Continuing with the symptoms that you would note would be failure to thrive with developmental delay, exertional dyspnea, And in cases with older children with Eisenmenger syndrome, cyanosis, clubbing, chest pain, difficulty breathing after physical exertion, and episodes of syncope, hypoxia, numbness and tingling of extremities, polycythemia, blurred vision, and enlarged liver are also common. From a therapist's point of view, when looking at health history and health assessment, our focus is on growth and development. We look at the patient holistically, but within each practices of our scope, we look at specific outcomes too. Generally, the team includes, but is not limited to, physiotherapy, speech and language therapists, audiologists, occupational therapy, dietetics, social worker, and psychology. Specifically, from a physiotherapy, speech and language therapy, audiology, and occupational therapy, we obtain our health history and assessment through an interview and collateral information which is obtained from the caregiver and close family members, as well as other key players such as your teachers. We also obtain information through clinical assessments and with the use of standardized assessment and screening guidelines.
So to diagnose a VSD, there are 4 important diagnostic tools that we need. The first being clinical evaluation, a chest X-ray, an ECG, and lastly an echocardiography. How early can a VSD be diagnosed? Well, it can be detected in utero as early as 16 to 18 weeks of gestation through fetal echocardiography. However, small to moderate VSDs can easily be missed during fetal echocardiography. Many VSDs are diagnosed postnatally at about 4 to 8 weeks of life when symptoms begin to appear. So your first important diagnostic tool will be your clinical evaluation, and signs and symptoms that you would pick up have already been mentioned. The next thing you will do is a chest X-ray, because a chest X-ray will support your suspicion that there's a VSD. What you'll see on the chest X-ray is cardiomegaly, which already tells you there's cardiac pathology, and you'll see increased pulmonary vascular markings, which indicate that there's active congestion in the lungs, vascular congestion. Next, an ECG will be done, or electrocardiogram, and with small VSDs, the ECG will be normal, but with medium to large VSDs, there will be changes on the ECG reading. The changes will indicate a left atrial hypertrophy, which will be indicated by a broad notched P wave in lead 2. The next change is a left ventricular hypertrophy, which will be shown by a deep Q wave, a tall R wave, and a tall T wave in lead V5 and V6. You may also find right ventricular hypertrophy, which will be indicated by a tall R waves in lead V1 and a right axis deviation. With large VSDs, you'll find biventricular hypertrophy. This will be shown on the ECG by high QR complexes and biphasic QR complexes in the precordial leads V2, V3, and V4. This is also known as the Cas-Wachtel phenomenon. Then you will need to do an echocardiogram. So normally a two-dimensional echocardiograph is used with color flow Doppler and if you couple this with Doppler studies, this establishes a diagnosis. And what information this will give you is the exact location of the defect in the septum, the description of the anatomic size of the defect, the estimation of right ventricular systolic pressures, the estimation of overall shunt size, and it would also identify complicating factors that are specific to the location of the VSD. The next diagram, this picture shows us a VSD
a large muscular VSD that has been visualized from different views. So the picture on the left shows us an apical four chamber view, and you can see there the left atrium, the right ventricle, the left ventricle, and we can see where the defect is. The picture on the right is a parasternal long axis view, and again this one shows your right ventricle, left ventricle, your left atrium, and the aorta, and again you can see the large defect, where a muscular defect in the septum. So there are other tests that are done, but they are not critical to the diagnosis of the VSD. Cardiac catheterization being one of them, and actually nowadays it is not used so much for diagnostic purposes, but the main reason you would do this is in patients that have pulmonary hypertension, because you want to measure pulmonary vascular resistance, and also it is useful in assessing the reversibility of the pulmonary hypertension. And this information is important because it will guide the interventions or management of the patient. So an MRI or magnetic resonance imaging is usually used if the echo images are inconclusive. It helps to delineate the VSD in patients with complex associated lesions such as coarctation of the aorta. It has very good tissue differentiation, so it shows you nicer images, and it offers excellent assessment of ventricular function, measuring the left ventricle and the right ventricular volumes, blood flow, and ventricular wall thickness. A CT scan, also rarely used, but it is useful in patients where the MRI scan is contraindicated, such as a patient that has a cardiac pacemaker. CT angio with ECG gating allows for direct visualization of the defect, and a CT scan can be helpful in identifying thrombi in the lungs or pulmonary arteries in patients especially that have developed Eisenmenger syndrome. And blood tests are not necessary for the diagnosis of a VSD, but with patients with Eisenmenger syndromes, they can help to identify the presence of polycythemia.
Good afternoon, everybody. I will be presenting on the medical and surgical management of VSD. The first medical management that we can implement in VSD treatment is by using diuretics and afterload reducers. So if we look at our diuretics, the most prescribed diuretic is Lasix or furosemide, and Lasix actually eliminates water and salts from the body. The primary goal of drug therapy in heart failure is actually to improve the cardiac functioning of the patient and to reduce the clinical symptoms associated with the condition, for example, edema, shortness of breath, feeding difficulties, and any exercise intolerance. Doctors may also pair the Lasix with aldactone, which is a less potent diuretic and is given due to its potassium-sparing effects. When diuresis is achieved, there is actually a decrease in the blood volume and thus less burden on the heart to pump. When we look at the addition of afterload reducers, we can see that afterload reducers are used in combination with diuretics and digitalis glycosides for maximum benefits. Our ACE inhibitors and angiotensin II receptor blockers, or ARBs, can be used to achieve vasodilation. Drugs from these categories actually achieve a reduction in vascular tone or afterload, and less afterload actually equals less myocardial workload. The second medical management that can be used is exercise restrictions. So in very small VSDs, no exercise restrictions are usually needed. In children who have had their VSDs closed later on in life, they should be tested to establish a safe level of activity. Significant VSDs and secondary pulmonary hypertension should be restricted to mild isotonic exercises such as squats, stair climbing, bicep curls, or even push-ups. Isometric exercises should be completely avoided by patients who present with significant VSDs and pulmonary hypertension. The third option for medical management includes the non-surgical closure of the VSD. So in these cases, transcatheter closure is done under the following circumstances. So where there is an isolated and uncomplicated VSD, certain membranous VSD where the anatomy is correct, a VSD location that is far from the tricuspid valves, a VSD location that is far from the aortic valves, and where there is adequate anatomical rim. The type of closure device used is actually called an Amplatzer VSD occluder, which you can see on the right-hand side of the picture that we have there. This is a self-expanding and self-centering device. It's made from nitinol wire mesh and has 2 ventricular retention discs. The technical success rate of transcatheter closure procedures is high at 98.1%, and the mortality rate is low. This sketch over here shows transesophageal echocardiogram, or TEE, which is the chosen imaging method when doing the transcatheter procedure. So the doctor will actually pass down a TEE transducer, and through ultrasound waves, a picture of the heart is formed on the echocardiogram monitor, and the catheter is then guided up to the site of lesion where the VSD would be present. In this sketch over here, we can see on my left-hand side where the VSD site of lesion is, and on my right-hand side where the closure device has been placed to actually close off the VSD. Now we're going to talk about surgical management. So surgeons basically have 5 surgical approaches for direct closure. The first and most common approach would be the right atrial approach, the transpulmonary approach, the transaortic approach, and the right ventricular approach. And also, lastly, the left ventricular approach. The sketch over here shows us the right atrial approach. This one shows the transaortic approach. Here we see the transpulmonary artery approach, the right ventricular approach, and the left ventricular approach. This approach is usually used to address the Swiss cheese type of VSD. The diagram provides a summary of the recommendations for when direct closure is warranted. Closure of small VSD is not required. Large muscular VSDs may be closed using percutaneous methods. Some surgeons may use pulmonary artery banding in low-weight babies who are at risk for heart block with repair, although the new trend is towards early complete repair. Moderate large VSDs with an enlarged left atrium and left ventricle or elevated pulmonary artery pressure and a pulmonary systemic flow of 2:1 warrants closure.
Future outcomes and needs. Potential VSD outcomes. Centered around any management strategy is patient and family. Between 85 to 90% of small isolated VSDs close early in life. These individuals go on to contribute well within society. Patients with moderate to large VSDs may have growth and developmental difficulties, thus surgical repair is recommended. Preoperative optimization of the patient is an important factor to consider. Nutritional optimization may be useful in assisting overall outcomes of infants under the age of 6 months. According to a single-center, large population study by Anderson et al., patients undergoing VSD repair overall have a good prognosis with low mortality rate. However, some potential complications may occur, such as left ventricular dysfunction, progression of pulmonary hypertension, residual or recurrent VSD, arrhythmias, valvular incompetence, Eisenmenger syndrome, endocarditis, embolization, and congestive heart failure. The American Heart Association no longer recommends antibiotic prophylaxis for patients at risk for bacterial endocarditis undergoing gastrointestinal or genitourinary tract procedures. It is recommended for dental procedures, respiratory tract, infected skin, or musculoskeletal procedures. Patients that may be considered are recipients of prosthetic cardiac valves or prosthetic material used for valve repair, unrepaired cyanotic heart disease, previously repaired congenital heart disease using prosthetics or materials within 6 months of surgery, previously repaired congenital heart disease with a residual defect close to the prosthetic material, history of endocarditis, and cardiac transplant recipients with valvulopathy. From surviving to thriving. In the event of perioperative complications, such as cardiac arrest, prolonged or complicated cardiopulmonary bypass, hypoxic events, and the pre-existence of genetic syndromes, societal integration becomes an important component of care. Societal integration involves multiple components and is managed by a multidisciplinary team effort. Some research shows that potential delays in the area of neurodevelopment, behavioral, psychological, cognition, academia, and exercise capacity may be prevalent in complex VSD lesions. Physiotherapy. Preoperatively, optimization of the respiratory function may be needed. Henningfield and Jones conducted a systematic review on perioperative chest physiotherapy in pediatric cardiac patients. Conclusions suggest that active therapies were more effective than manual therapies. Post-operative factors of concern to the physiotherapist may be pain, postural compensation, respiratory complications, and in the event of neurological fallout, lengthened ICU stay, and ICU-acquired weakness. Cardiac rehab remains an underutilized domain which may be useful in improving quality of life outcomes. Tekkanen et al. In 2012 conducted a systematic review on pediatric cardiac rehabilitation, where most studies focused on aerobic and resistance training, and no adverse events were reported. Occupational therapy. Literature reviews by Innes and Rogers highlighted the comprehensive needs of children with congenital heart disease. There may be deficits in neurological, cognitive, behavioral, and psychosocial domains. These studies suggest more holistic cardiac rehabilitation is needed. The occupational therapist will assist in enhancing independence in age-related participation, optimization of occupational performance in areas of self-care, productivity, leisure, and visual perceptual or fine motor skills. Speech therapy. De Rosa Pereira et al. Presented data that suggests dysphagia may occur after surgery in infants with congenital heart disease. Though they had a limited sample size, dysphagia and speech-language delays may be prevalent in those who have underlying genetic syndromes or had perioperative complications. Audiologists may play a role in ototoxic monitoring with patients who are receiving diuretics. Our references. Thank you very much for your time. Have a wonderful day.
Thank you. Agree. That was a presentation packed with a lot of, great content, detail. And again, as previous presentations, they review a lot of the content that has been done in the past in a different way. Again, the layering of the information and our ability to retain knowledge and use examples as well. So that was exceedingly well done, as were the previous two. I like the way it was done by different members of the interprofessional team, and you looked at the role differences and how they impacted and how your role impacts these patients and their families. So thank you very much. Does anyone else want to provide any, we have some feedback on the chat as well that people can read. Any questions? For Sarah, Lindaway, Nicole, Duone, and Prathista. Okay. So I'm just going to stop the recording.